Say goodbye to monotonous books and say hello to colorful, interconnected mind maps. In this series, we will quickly help you revise important concepts with the help of mind maps, which you can access later using our app. In this video, we will quickly revise an important type of malocclusion, which is very commonly seen, which is class 2 malocclusion. It is also known as retrognathism or overbite and is marked by maxillary teeth positioned significantly forward in relation to the mandibular teeth. It is characterized by a prominent maxilla and/or a deficient mandible. The etiology of class 2 malocclusion can involve various factors, such as genetic and congenital factors, improper forceps application during delivery, retarded mandibular growth compared to maxillary growth, habits, congenitally missing teeth, and malformed teeth. It can be classified into various types according to Engel's classification of malocclusion. Class 2 can be further divided into Class 2 Div 1, Class 2 Div 2, and Class 2 subdivision. Class 2 is characterized by the distobuccal cusp of the upper first permanent molar occluding with the buccal groove of the lower first permanent molar. In Class 2 Div 1, the maxillary incisors are proclined. In Class 2 Div 2, the maxillary central incisors are retroclined and overlapped by lateral incisors. Van der Linden classification is a system used to further categorize Class 2 Division 2 malocclusion into Type A, where the upper central and lateral incisors are retroclined but not overlapped by the lateral incisors. This is the mildest form of Class 2 Division 2 malocclusion. Type B, in which the upper central incisors are retroclined and are overlapped by the lateral incisors. Lastly, Type C, where both the upper central and lateral incisors are retroclined and are overlapped by the canines. Engel's Class 2 subdivision, when the molar relationship is Class 2 only on one side, that is, unilateral. The different subtypes of Class 2 present with different extraoral and intraoral features. In Class 2 Division 1 malocclusion, extraoral features include a typically oval-shaped face with a mesocephalic to dolichocephalic head shape. The profile of the face is convex and the face is posteriorly divergent. Incompetent and stretched upper lip is seen with deep mentolabial sulcus and lack of lip seal. Intraoral features are Class 2 molar relationship, proclined upper incisors, deep bite, exaggerated curve of spee, and narrow V-shaped upper arch. For Class 2 Division 2 malocclusion, extraoral features seen are squarish or brachycephalic face, straight to mildly convex profile, short upper lip, thick flabby lower lip, and adequate lip seal. Intraoral features include retroclined upper incisors, increased overbite, deep bite, exaggerated curve of spee, and a U-shaped upper arch. Management of Class 2 malocclusion involves different approaches depending on the severity and growth stage of the patient. Some common management strategies are growth modification, either by restricting maxillary growth and enhancing mandibular growth. In mild to moderate Class 2 malocclusions, after the growth period, orthodontic tooth movement can be used to camouflage the underlying skeletal discrepancy. In severe Class 2 malocclusions, after the cessation of growth, surgical intervention may be necessary. Functional disturbances associated with Class 2 malocclusion, such as mouth breathing, can be addressed using oral screen. Improper lip posture and activity can be managed by various methods as seen on the screen in this section of the mind map. Management of Class 2 due to mandibular deficiency can be done by functional appliances like twin block, activator, Frankel's FR2, Herbst appliance, or various bite jumping devices. Management of dento-alveolar Class 2 malocclusion with a normal skeletal relationship has different management options. In cases where premature exfoliation of primary teeth or extraction of permanent teeth has caused mesial drift and subsequent crowding in the upper arch, space regaining devices can be used. These devices, such as springs, screws, or extraoral appliances, help to distalize or move the upper buccal segment backward to create adequate space for alignment and correction. When both the upper and lower anteriors are proclined, there is a spacing present with a deep bite. Orthodontic treatment can be aimed at retracting these teeth to improve the overbite and overjet. But before initiating treatment, persistence of any abnormal oral habits should be checked for and treated. For management of Class 2 malocclusion in adults, dento-alveolar compensation can be employed. This involves reducing tooth material, such as extracting maxillary first premolars and retracting the maxillary anterior teeth to camouflage the underlying skeletal issue. For most severe class 2 malocclusions with a significant skeletal discrepancy, orthodontic surgery may be necessary. It is typically performed after the cessation of growth. Pre-surgical orthodontic measures are necessary in cases with exaggerated curves P. For maxillary prognathism, surgical procedures like total maxillary retropositioning or partial maxillary retropositioning, which is more common, can be done. For mandibular retrognathism, bilateral sagittal split osteotomy, inverted L osteotomy, C osteotomy, or subapical surgical procedures are done. You can note down points about it from this section of our mind map. Lastly, for Class 2 Division 2 malocclusions, functional appliances can be utilized during the mixed dentition phase to promote forward growth of the mandible and correct the bite. In mixed dentition phase, maxillary first premolars are commonly extracted to alleviate the anterior deep bite, and additional appliances like bite planes and arch wires with anchor bends may be used to achieve desired results. With this, we have come to the end of this video discussion. Hopefully, we have helped you revise this topic quickly. Now you can head over to the MCQ section of our app for solving some questions. Happy learning!